So this is a mandible.
Yes.
This looks like mandible.
Yes.
So we do this.
So the thumb is rotating.
Yeah, the right thumb is rotating.
But the thumb is not flaring out.
No, it doesn't do this and it doesn't do this.
That's the key.
That's the key.
No, it's an interesting point because I learned actually a couple of years ago, I learned that a lot of like NFL football players have sleep apnea. And I was shocked to hear this because, of course, these guys probably have amazing jaw structure, but they're just too heavy and too muscular even. Maybe it doesn't even need to be fat. Maybe it's muscle too, like you're suggesting, where when you're just too big and massive, the airway, because it's really such a fine area, the muscles constrict it just enough to create problems.
Exactly. It's a flexible tube right behind the airway, and the muscles, they have more power than this empty tube, right? Yeah. And the muscle that's exactly, you're right. Now, this is a question that you started it. Does every MMA treat a sleep apnea? Well, that's a good question. Or upper airway resistance syndrome. So the article that was published by Dr. Zaghi, which is one of the, and you know Dr. Zaghi, right?
I do. I
think that you need to invite him on your program. He's going to be a great asset. This guy is a genius and such a good clinician.
Well, I met him a couple of months ago, and I was very impressed, and he was very kind to me, and he actually treated me a little bit. He gave me an injection to eliminate some of the scar tissue of my tongue tie release from back in 2017. He gave me a scar tissue dissolving injection. I forget what it's called. Yeah. But he was very, very nice to me.
Yes, very, very genuine guy, and is very great clinician.
I just interviewed his partner, Kevin Coppelson, a couple of weeks ago.
Oh, really?
Yes.
So are you going to air that soon?
Yes. It'll be aired before this interview.
Okay, great. So Coppelson, I work with Kevin, and he's another great clinician. I'll show you a case that we did with Kevin also. Mm-hmm. So now I referred my tongue tie cases that they're very severe to Dr. Zaghi, and I don't have any problem to say that he's the one that does it right.
That seems to be the consensus globally, is that Dr. Zaghi is the guy to go to for tongue tie release.
Exactly. So now he published this article with Dr. Gimina and a bunch of other clinicians. Dr. Riley's pioneer, Powell and Riley, pioneer in the area of MMA. And they consensus at that was that they did the 389. I mean, they did so many, 500. I think that so many, how many numbers?
Over 600. Over 600.
So, and then at the end, 85% had surgical success. What is surgical success? It's meaning that the MMA did not relapse. All right. But the cure for sleep apnea was 38%. So does it mean that 60% or 62% did not respond very well? And that's the question, why not every MMA? Because it is a multi-level. And this is our patient. This is a patient that had extraction like the other, patient. And we told him that let's get engaged with the stage 1, stage 2. Stage 1, it is going to be expansion of the jaw with DANE, and then a stage 2 MMA. Now, the initial diagnosis of his sleep apnea was 19.9. Ron, I want you to remember this number, 19.9. All right. And then with the use of the Apnea-TX, we did the split night sleep study, half of the night without the appliance, half of the night with it. And the Apnea-TX managed the sleep apnea very well. So this is the appliance that he was wearing before, and change his bite the way that you see. The change of bite here is because of using that appliance. Now, we gave him the Apnea-TX. It worked very well. I showed you his airway with the use of Apnea-TX is under 5. And then he's getting ready for the MMA surgery. He does the MMA surgery. Ron, what do you see in his airway? Is it large enough?
It seems huge.
How many times? 3 times?
At least.
All right. So let's look at this. Look at his airway. Look at his number after surgery.
Hasn't changed.
Remember,
much.
It was 19.9. He's 17, and he's now mad. But he cannot be mad. He didn't follow the protocol that we created for years. And, guess what? What is the reason? This is what you pointed out, and that the other doctor, the ENT doctor, also mentioned his nasal cavity is narrow.
Wow,
right?
Look at that.
All right.
Did he have a segmental LeFort jaw surgery?
One piece.
Look like it. One piece.
Yeah, one piece, because we didn't expand the mandible, and surgeon couldn't expand the maxilla.
Right.
But the airway is large. Doesn't matter.
The pharyngeal airway is large.
Yeah, is large. Well, what we did, we sent him for turbinoplasty. All right. And you can see that from before that, the turbinate is very small. Now they're large. Right? So before and after, this is his face before and after. Look at this AHI now. Cured.
And that's just as a result of the turbinoplasty. What is that? Is that a reduction of the turbinates, or is that complete?
Right. That's what Dr. Zaghi also is very good at, is reduction of turbinates. Yes.
How does he do it? Do you know?
Well, one thing that you need to be careful, and do you remember that you had a great clinician on your,
Coral Tao?
YouTube? Yes.
Yeah.
So she mentioned to you that on top of the, the skin or the membrane on the top of the turbinates, they have these sensors that they feel the flow of the air. So they need to do, and they used to cut them. And that's that. Now they are to shrink them and they suction them out. So the surface stays the same, except that wrinkled maybe, but they don't cut them significantly, because you know that empty nose syndrome can happen.
So are you talking about the ablation?
Turbinoplasty. Yeah.
You're talking when they debride the inside of the turbinate and they remove tissue from the inside of it, or are you talking about the IR ablation of the turbinate from the outside?
Either one of them. Ablation meaning that sucking the juice from inside of it and reducing. And sometimes also they need to kind of cut it a little bit. Yeah, is a combination. But at the same time, this is after. But the problem, what is the problem with this? It comes back. Turbinates, they grow back again and again. So we could avoid it if the clinician comes here and then has successful expansion of the nasal cavity, meaningful expansion, not 2, 3, 4 millimeter expansion that is about 7, 8, 9, 10 millimeter successfully. At that requires expanding the mandible if they can. I go through this. I showed you this before. It's like the same case, much more complex. His arch was so narrow.
Can I pick up on a point you just made?
Sure. Yes.
So some people assert that even after a nasomaxillary expansion, that the turbinates will grow to fill even the new space after the expansion. You're saying that that's why you need what you called a significant expansion of 7 to 10 millimeters. Do you find that 4 to 6 millimeters is often not enough to prevent the turbinates from refilling the new volume? You think that the bigger expansion helps prevent the turbinates from ever growing so big that they fill the nasal volume again?
Is my opinion and my experience. But let's talk about this. So one of the things that during sleep apnea happens, the upper airway in the usual manner when you close your mouth, there is a -5 centimeter of negative pressure inside the pharyngeal area when you close your mouth. Now, this can translate during the sleep apnea to -15, vertical, what we call height of the water. And sometimes with upper airway resistance syndrome severe to 50.
That's a negative pressure that you're talking about.
That's right. So it means that you breathe, your lungs expand, but this is obstructed, right? Here is obstructed, and then the negative pressure is going to be generated. Yeah. So these turbinates are floating is not stationary. These are during the day, one turbinate gets larger, the other one gets smaller, and that's how they manage the airflow and moisturize it, and and also make it warm. So if by any chance the sleep apnea persists, so the airway nasal cavity is narrow, and then that contributes to development of the negative pressure, is like suction, is going to suck the fluid into the what we call the turbinate, and can enlarge it. That's one of the factors. That's why treatment of the sleep apnea should be the way that also the nasal cavity, and they can do it during the MMA, can be done, right? But at the same time, not on everybody. Why can be done on the cases that they have run significant counterclockwise and the base of the palate, floor of the palate drops significantly down. So just imagine that you have a room, nasal cavity, right? That nasal cavity has width, has height, right? And front to back. Mm-hmm. Now, either you can expand it. So, and, this room has turbinates in it, septum in it, and get crowded. If you can, drop the floor of the nose during the MMA, then the vertical height of that room is going to be increased. So volume can increase and airflow is going to be better. But if the case has the way that, the base of the nose cannot be dropped, my experience, and I'm sure that right now, if surgeons, they hear this, they are going to, argue with me. But this is based on the experience that I have done sleep before and after with my clinicians and surgeons. So if by any chance the case has opportunity to significantly drop in a counterclockwise rotation, the floor of the nose, then successful, you don't need to have too much of expansion. Right. But if the case cannot tolerate so much of counterclockwise, then expansion in the first stage can help.
Interesting. So patients that have a relatively flat occlusal plane, who, if they're going to do an MMA, it's going to be more of a straightforward advancement rather than a counterclockwise rotation. There's no downgrafting really, because the downgrafting occurs as part of the upswinging. The back of the palate drops so that you can get the rotation. Not all patients qualify for that, because some patients, if their occlusal plane is flat and you counterclockwise rotate them, then their chin comes too far forward and they look really weird. So some patients just don't qualify for counterclockwise rotation surgically. And those patients don't stand to gain much nasal breathing improvement from the MMA.
That's one of the things. That's one is a multifactorial. That could be one of them.
Even if you do a segmental and you expand a patient that's coming straight forward with the MMA, do they get much nasal breathing improvement that way, or not really, because you're just really widening the floor of the nose, but not the top part of the room? There is
going to be a lot of, this is very controversial because there is a documentation that during the LeFort one, the way that they do it is in the lower 1/3 of the LeFort one. Usually the cart inside the, underneath the lip is the lower 1/3 part of the, nasal pyramid. And they believe that most of the airflow is the lower 1/3. So the argument is, no, if they do the LeFort one expansion, they can get the palate wider if they do it right and the lower part of the nasal cavity pyramid. But at the same time, well, then subject like that, or I have seen patients this year, I got referred and second opinion, because my practice these days is revision, right? And we have significant number of cases that we see revision, and a young person at early 23 had the surgery, at age 23 MMA, and 3 years later is back and asking for, help, because still has sleep apnea and is not gone. They did a turbinoplasty, comes back. And those cases, we need to be careful to do expansion after. They're not as easy case, right? And then there was another one that just finished, and these are great clinicians, great orthodontists, great surgeons that they did this, but they approach it from the view of the orthodontics orthogenetic, not treating a sleep apnea, just bringing the jaw forward. So now that's the argument that we have. Even with the LeFort 1 run, there is a chance that although they expand the maxilla, cannot improve the airway constriction.
Can I ask you what challenges having a prior jaw surgery pose to someone seeking MARPE after the jaw surgery? What happens if you try to expand a palate after jaw surgery?
It depends that how long after, because one of the things that happens is that, especially the technique that they do, is it MARPE, is going to be dome, is going to be mine. So just imagine that this area is healing. So they did the MMA and that area is weakened and is not as strong. And cases that I'm getting for the revision that, they had the MMA before and then their sleep apnea was not improved. Now somebody came and started expanding the upper with the technique that put a lot of pressure on these healing areas, that it takes a couple of years to become strong enough. We have done it on patients that they were, 5, 6, 10 years out of the, what we call the LeFort 1 and MMA surgery, and successfully we could expand it. But at the same time, if you put too much force, like midline piezotomy only or MARPE only, this can get distracted or can break away. I'll show you cases that are coming. And also unilaterally, one can pop out, depending that which side is a weaker and, conjunction.
So is it that the MARPE always splits at the point of least resistance? And if the union after the surgery isn't solid on both sides, then the weaker side will fracture? Will it actually fracture at the site of the LeFort cut?
It can. So,
please.
Of course. So the thing is that surgeons, they see it. We have seen it with our surgeon. I'm sure that experienced surgeons, they have seen it. But at the same time, as orthodontists that I'm treating these cases that they need a revision, I'm seeing it. Yes. So it means that area, if it's the weakest point of the chain and is not healed, it can fail and start giving up and fail.
Do the surgical plates ever pose a problem to the expansion? Like they resist the expansion? And
of course. So the cases that we have done a couple of times, we had to remove the surgical plates. I'm sure that there are some clinicians out there that they argue with this, but in those cases, we remove the plates, be sure that the quality bone and the healing in that area with direct supervision is healed and X-ray supported, then they're safe to, and the cases that we have done for expanding them after MMA, we need to be conservative. That there is the bone is, there is completely healed. There is no presence of non-union or anything on that side. So, yeah.
Have you ever expanded a patient who had a segmental LeFort?
Yeah, this is a case that we did. One of the cases that we did it had the segmental LeFort. She had 2 MMA surgery with counterclockwise, and she had significant resorption and over the open bite for 5 millimeter. She didn't want to have the what we call the another MMA, so we had to do it with the just like what you call MARPE, and we call it main. So we did it. Yes.
Wow, that's incredible.
But we had to remove the plates.
And so even after some time, even the segmental LeFort gets enough union that it can withstand the force of the MARPE, and you'll get a midline split?
Yeah. But at the same time, I think that those cases, as Dr. Liu from Stanford is going to argue with this, because what I'm saying that is going to support this, that's why DOME was created. DOME, which is going to do the side, cuts. So DOME is going to remove the stress that expansion of this is not going to be translated to cheekbone, right? and then the unilateral popping out of the cheekbone is not going to be, is going to be prevented.
So
that's one of the reasons for DOME.
Oh, DOME helps MARPE after jaw surgery.
Yeah. So if I do the this expansion that I mentioned to you, we do it with almost the same technique that DOME does, except that we call it DANE, distraction assisted nasomaxillary expansion. The name is very close. The technique is a little bit different, the application of the appliance. But Dr. Liu and clinicians at Stanford, they do DOME. I showed you on that level of the surgeries that they do DOME, includes the buccal cuts beyond the bones. It's like a SARPE cuts, there. And that's because they don't want to have the unilateral expansion or, the cheekbone or the zygomatic bone get distracted.
Right. In other words, one way of dealing with the problem of differential union after jaw surgery is to just sever all union completely and then start over so that you have zero resistance on both sides.
That's what we did for these cases, yes. Yep.
And because you've worked with Dr. Alfie, you know that his maxillary post-surgical plate is one plate that comes all the way across, including across the midline, as opposed to separate plates on either side where the midline is free. Definitely with a plate like that, if you want to do expansion after, you need to remove that plate. Otherwise,
exactly. Yeah. So the thing is that the way that we do it, which practically using DOME, or we call it DANE, the surgeon at the time that they do it in hospital, they need to remove the plates, and then they do the cuts, and osteotomy is all the way back to the pterygomaxillary fissure, and then be sure that maxilla is going to expand symmetrically.
Mm-hmm. Yeah, definitely better to do the MARPE before surgery.
That's right. It is going to be a MARPE or some adult patient that they cannot. So we can talk about that. So if we can go forward through this case, also this is a case that I showed you this case before, that we expanded the lower arch, and his arch was so narrow that they wanted to cut his tongue half so it can fit in that narrow arch. All right. Is that ethical to cut the tongue half? They do it. We do it. It's part of our protocol on patients that they don't respond to MMA, or we do DICE. Remember, the drug-induced, sedation endoscopy. So we do the base of the tongue glossectomy if it's necessary, but is from A to Z. These are stages of later if you're not successful with the regular procedures.
Yeah,
but those are useful. Yeah,
that's like not Z, but that's like Y maybe.
That's right. Is even close. Yeah. So in this case, we just expanded the lower jaw, and he had already, implants on upper and lower, but still we were able to expand. And then in this case, also, if you recall, we put the implants there, and you can see the side of the expansion was here, and this is the implant that we put later, and this is after MMA. And this case has been out of the treatment for, again, close to 14 years. And this is AHI was 50 in the beginning, and dropped to, I believe that was, if I remember, 2.3. After the first stage run, when we did the expansion, dropped to 23 from 53. And then at the end was 2.3. 2.1 was really high.
How did you manage the implants? Did you just, you closed the gap using another implant so that you didn't have to mesialize the existing implants or move them at all? Is that right?
Yeah, so we moved everything around them successfully. So it was with the LeFort that we did and with the MSDO that we did. And remember, at the time, again, we were calling it DAME now. When we expand the lower jaw, second molars, they don't get expanded too much, right? It's just the anterior that gets expanded 10 millimeter. So it was not so difficult in the back to move his molar. These are both implants, to move it about 3 or 4 millimeter out. So during the LeFort, then the surgeon, Dr. Trimble, expanded the upper jaw was about 6-7 millimeter expansion, 8 millimeter. That brought the implants close together to the point that we didn't have to change them.
And why did you use the lingual braces system on this patient? Did he want that?
So,
he requested
listen to this. I tell you a story. So he came to me first and he said that I want to have Invisalign to fix my, my teeth. And he didn't know that the relationship of the teeth and jaws and airway. And I told him, so, if by any chance, we have the opportunity to, fix this dentally, but if you give me a little bit chance, we can make it the way that maybe you don't need to wear CPAP anymore. He said, what? I said, yeah, we have the treatment that you don't need to wear CPAP anymore. And I told him about the expansion of the jaw. Very, very smart guy. He disappeared, right? And one of the reasons that he disappeared because it doesn't make sense, and nobody in the community was supporting the idea that is doable, right? So then I'm hearing from
just so the audience has some context. This is 2012, so this is way before this expansion stuff became mainstream.
Yeah. So, and then I'm hearing second opinion from Harvard View here, from Mayo Clinic, Cleveland Clinic, that everybody says that, okay, this is what we are going to do. First, we are going to do midline glossectomy, so make your tongue fit. And then if it doesn't work, you can go back and let Dr. Trimble and Yousefian, they bring your jaw as MMA. Well, it took him about a year. Then he came back about a year later, and he said that, Dr. Y, well, it seems that what you are saying is practical. You show me cases that you have done before, but at the same time, in my line of work, I cannot have braces because I lose my credibility. Can you put inside braces? And I said, sure, we put inside braces. So that's
what was his line of work? Do you recall?
Attorney.
Mm-hmm.
And they wanted to cut the tongue of an attorney.
Yeah. Maybe. Well,
so that's unethical.
Yeah. I could make jokes about that, but I won't because maybe he was a good attorney.
That's right. So anyway, it improved his situation, and this is. Is stable. And this case was so interesting, the way that we did it and avoided those. And look at the site of the expansion. Is it healed? You see just shadow from it. And this case published in 3 peer-reviewed journals. And usually they want you to publish and say, done, don't publish it anywhere else. But this was published so many times. I go through this quickly. 53 AHI. And Tori's, and she has also implant here run. Mm-hmm. And 53.8 AHI in the supine was 65. We expanded the mandible. You see the side of expansion. And this is 2017. What was the beginning? I don't have the date for. Yeah. Do you see the? Yeah. It is more than, I think that was 2015, or she started in 2014. So,
I notice a lot of your patients have gold caps and fillings.
So what does it tell you? We have been doing this for a long time, 20 years.
Older. Yeah. I just want to comment that the gold restorative work is really beautiful.
Beautiful. But I wish attractive, but it's beautiful.
Why did dentists stop using gold? Was it a cost thing?
Aesthetic. Well, these days, gold teeth are not, although a lot of athletes and, they still wear it even in front. But I think that most of it was for aesthetic reasons that, they didn't want to have a gold, but it's one of the great material that can be used.
Yeah, because it expands and contracts at the same rate that the tooth does, right?
Yep. So,
gold is more aesthetic than amalgam, though, isn't it?
It is. Yeah, definitely. I agree with you 100%. Yep.
I like the way it looks personally. Plus,
Sure.
who doesn't like gold? I mean, having a little bit of gold in your mouth, it's not the worst thing.
I agree with you.
And
so I'm carrying gold with me. If I need it, I can yank it out.
Exactly. If you ever need to jump the border and you're in a pinch, you have something to barter with.
Well, just be careful that don't leave your mouth open when you're traveling.
Fair enough.
They can dig it out for you. I'm kidding. Okay. So, but pay attention to this. Look at this, nasal cavity. So one of the success story at the time when we didn't have MARPE run was turbinoplasty. But we are doing it less and less because we have MARPE. This is something that so today we are getting very, very carried away with this term of MARPE. Now we have a new instrumentation run, right? We have a new instrumentation that we want to try it. We have a new toy, new car, they want to drive it. Come on. This SARPE has been around for 50, 60, 70 years. This is a guy, and I want to look at this, how narrow it is. How narrow, and this is an extraction case, definitely, all right? But the amazing thing about this case, we did SARPE, Dr. Trimble did SARPE, and DANE. This is expansion. So it's about around 2015 till now, and they restored his teeth. He has gold. Look at the AHI.
No MMA, just there is an MMA.
No, it's just mandibular advancement.
Just mandibular.
Yeah, but because his position of the maxilla was fine. So the power of expanding the lower jaw and then an upper jaw, remember, upper and lower, all right? And enhancing the nasal cavity. And you notice around here, see that how wide, narrow was and how wide it is, all right? So I think that these clinicians that right now are coming and say that Tooth-Borne, I know that you're against the Tooth-Borne, but it's a combination of now we have another tool. Not only we can use teeth because teeth are so strong. They are so strong to support the bony segments during SARPE. Now we have one more advantage to add like more teeth, like, TADs or micro-implants implant. But we cannot ignore the present teeth that patient has. We were doing significant number of these SARPE, before, and we were treating. This is case that is 100, all right?
I'm not sure I understand the point that you're making, though, about...
So the reason that is they say that the so-and-so, and one of the things that, well, do we have a Tooth-Borne appliance or we have a Bone-Borne appliance? And they emphasize that definitely you need to have a Bone-Borne expansion to put it in the middle of the palate with no arms to expand.
What's the problem with that?
Well, the thing is that then you're ignoring the rest of the teeth. And I'm going to show the problem that I have with that later. But this is the case that this is a Bone-Borne, this is a Tooth-Borne appliances, and they did the surgery with these and successfully. So just putting the, the techniques that they use, just the Bone-Borne, and say that that's the only way to go. I think that some of us, we have issue with it.
Well, but in order to make Tooth-Borne work, you need to do SARPE, though.
In order, yes, that's right.
This guy had SARPE, so
that's right.
I think just to be devil's advocate, I think the hope with MARPE is that you can at least minimize the amount of surgical assist that's needed. Maybe you just need piezo midline or something.
But remember, Ron, DOME is with MARPE and SARPE cuts. DOME procedure is with, a combination of TADs, all right, and SARPE cuts.
But some MARPEs are done without DOME.
Yep. Mm-hmm.
And even if you do MARPE and DOME, I would think that you would get less dental movement with the MARPE than you would with the Tooth-Borne expander after DOME. Do you find that to be the case?
Well, is the degree that how strong are your micro implants, and so your micro implants they should be strong. Your arm, and we get to that. So when we go forward, we get to that.
Okay.
So, and this is the patient that they say that, well, expansion of the mandible is going to damage the joint. So let's look at this. So patient, and Ron, I know that you have eyes of the dentist. Look at the joints. What do you see? This is the joint from the front on the right side here. The joint, top of 1/3 of the top is gone maybe, or 1/4. And then on the left, it is keep going. This is a severe osteoarthritis.
Mm-hmm.
All right. And this is the MRI. And what it shows that on her right side, she has damage. On the left side, she doesn't have, almost half of the condyle is gone. And you see it here, right side from floor. We are looking from front. So Ron, this is from the side.
What's the advantage of using MRI as opposed to cone beam CT to look at the temporomandibular joint?
So if you go here, and this is a CT, mm-hmm. right? So it shows bone, but at the same time doesn't show the position of the disc. So it's the best way to read the bony problems like osteoarthritis, osteophyte. So this thing here is the result of chronic deterioration. See, we call these bird beak, that meaning that the top of the bone is gone chronically. And this is a severe osteoarthritis here. But then when we go to the MRI, is soft tissue. And you see the disc right here. This is a displaced disc. Do you see it here?
The disc is the black area.
Yeah. It's different modalities. This is a T2. And then it shows that the bone is kind of black. You see, this is the bone. This is the condyle.
And the disc is displaced anteriorly.
That's right. So this is the disc. So this is the right side. Let me orient you to this. So this is the ear hole. This is the socket of the joint. This is the condyle, right condyle. And this is the disc that is displaced. Now on the left side, again, we see the ear hole.
The disc is supposed to be right on top of the condyle?
That's right.
Oh, that's not even close.
On both sides, it's not. This is, and you know what? These cases, let's look at the case. These cases, actually, they're easier to expand the mandible because when you have a very dense and healthy bone, condyle, and the rotation is so little on the distraction because it's rotation. Remember the way that the DANE is just rotation. There is no allowance for distraction side to side. So if you look at this case, that first we did the impression. Let's read the diagnosis of radiologies. Right side, moderate to marked degenerative joint disease with active inflammation of the joint and a joint effusion, meaning fluid in the joint, effusion. Limited range of motion, internal dearrangement with the persistent anteriorly sublux, displaced meniscus. On the left side, severe degenerative joint disease with complete erosion, bone is gone, of the head of the mandible, mandibular condyle, active inflammation of the joint with the joint effusion, fluid in the joint cavity, and likely loose bodies, meaning that there were broken pieces of bone in her joint because of the piece of mandible broke. And limited range of motion, internal rearrangement with a persistently anterior sublux meniscus. And her sleep apnea was 23.
Don't let Dr. Wolford or Dr. Movahead see this one.
There is no way that either one of them let this one go.
No.
There is no way that either one of them, and they are right. So, Ron, the reason that we had to do it, we didn't have any other option. At the time, we didn't have anybody to do this. And also the total joint replacement was not as predictable it is now. So and do you know what? I need to tell you that we had to do a total joint replacement for a young 23-year-old female patient that the joints were trash worse than these. All right. And then the argument is, and the insurance company wanted to have consultation with Mayo Clinic. And then the discussion was that if we do just MMA, there is no way that condyles can tolerate this significant advancement of MMA. Her face was very, very retruded, sleep apnea. So in case of 23-year-old, they decided that more predictable is going to do the total joint replacement. At the time that we did this case run, we didn't have the option. So, but at the same time, I want to show you how even vulnerable joint like these, how they respond to the DANE and expansion.
If I could just interrupt very briefly.
Go ahead.
You mentioned that they argued that the joints couldn't tolerate the stress that the MMA would put on the joints. What stress does MMA put on the joints? Why does that cause stress? Shouldn't that cause relief?
So I ask question, Ron. So you are going to have in matter of 2 hours, right? Significantly rotate the lower
Dr. Alfie, 1 hour.
Okay, 1 hour, whatever. So that 1 hour, 2 hour, 3 hour, but it's short period of time. All right.
I'm messing with you.
I understand your point. Yes. So you're stretching this soft tissue, and you know that how strong this. You're putting one rubber band that puts 45 or 150 gram of force. When you pull this forward, we are talking about pounds, 20 pounds of force that is pulling this back. All right. What is holding the lower jaw? Now you know better than me. Condyle. All right. If the condyle is not strong enough, and as we learned from Dr. Arnett, if the top of it is not corticated and is not dense, is melting it down. I'll show you in one of the videos last time I showed you. So the mandible is going to move back. So significant part of the instability of MMA, it is the condylar resorption if it happens. We had Reza Movahed Dr. Movahed was presenting to us, and his case that was showing, he does also a lot of revision, and case after case is revision, mandibular resorption, condylar resorption after MMA or BSSO. Yeah, so that's the reason is the connective tissue that is pulled forward is going to bring everything back. That's why one of the uses of ApnoTX, Ron, that I explained to the patient, every night we put them on this appliance that is going to hold the jaw forward and adapt the pre-mandibular connective tissue, stretch it every night. So when they do the MMA surgery, we don't shock these muscles in matter of 1 hour or 2 hours to bring them forward, because we already every night we stretch them forward. So the likelihood of they adapt to this advancement better, and at the same time we are recorticating the joint during 1 year before surgery, the success is going to be not 100%, but is going to be majority of cases.
That's amazing. So do MMA patients, if they have a mandibular advancement, do they actually feel tension in their mandible after surgery? Do they feel that their mandible wants to spring back under an elastic force?
Depending that how much. If Dr. Alfie or Bobak or Movahed, they bring 15, 20 millimeters forward, of course they feel that, this is a stretch. They feel it like pain and discomfort. All right. But if they bring the jaw 10 millimeter forward, maybe they don't feel it as much.
Is that contribute to when patients after an MMA surgery say that they have a hard time opening their mouth? Is that the tension?
Part of it. So part of it is multifactorial, Ron. And the reason is that these are very, very educated questions. But at the same time, what does it mean? I want to just simplify it the way that, I know that you are so educated, deserving a PhD degree in dentistry, but the rest of your audience may be just new to this area. So when they bring the jaw forward and, advance the jaw so much. So, and the surgery creates insult, all right? A lot of inflammation. The inflammation, that fluid, it is going to make the muscles, the tissue kind of puffy and movement is going to be. But there is another physiological component that they call it co-contraction. What does it mean? Co-contraction. Meaning that humans or animals in nature, when they get hurt, all right, there is a protective mechanism. So what does it mean? Usually, hands, extremities, they have flexor and extensor muscles, and they work periodically. This one works, this one relaxes, so in conjunction with each other. But then when animal gets injured or humans, they get injured, what happens is that the brain sends the information to both flexor and extensor muscles to work at the same time, all right? So it creates the fixation of that organ so it doesn't move, it can heal, all right? So animal in nature, when it gets hurt, goes somewhere in the cave, stay there, moveless for a couple of weeks till heals. Human beings, they don't do that.
We go to bed.
This is injury, yeah. This is injury, significant injury, cutting the bone. So what happens, all these muscles are going to go to contraction, spasm for a period of time. That's another factor. Inflammation, all those is a multifactor.
Wow. That's an amazing explanation.
Yep.
It's almost like nature's way of creating a cast.
Bracing, yes. Bracing the system so it doesn't move. So example, you're doing some, home repair or something, and then suddenly you bump your funny elbow.
Yeah, funny bone, yeah.
Funny bone and elbow.
Mm-hmm.
So next day you wake up and the whole hand is painful. Why? Because it's a co-contraction. The whole muscles also in spasm, so you don't move your hand, you can heal. That's a sample of co-contraction.
Have you ever heard of this phenomenon of after a patient wakes up from an MMA surgery in the weeks after, even if they have a big advancement, they feel like their airway got worse? And the explanation I've heard for this is that because after MMA, sometimes all of the muscles of the entire airway tense up. Is this part of the same phenomenon where after the MMA, there's trauma and there's just what did you call it? It's a triggering of all the muscles to brace, and that actually constricts the airway.
Yes.
And
well,
with time, it relieves.
So in the beginning, it's not unusual. So we need to be careful on that. And there is what we learned from Dr. Arnett was ICE, intracapsular inflammation, or effusion or, fluid, ice. So ice that happens into the, joint, which is after surgery because of trauma to it, it inflames, so it doesn't let the mandible sit. So all this inflammation in this area also, making the airway constricted. So, and it doesn't happen in everybody, depending that if David Alfie comes and bring the jaw 25 millimeter forward, or Bobak does, there is no way that type of inflammation, they usually feel better breathing through the, pharyngeal area. But if they, they do the same type of insult and advance the mandible 5, 6, 10 millimeter, of course, they didn't advance enough, and that inflammation can impact them.
Mm-hmm.
Makes sense? Mm-hmm. So going to this case, we did the expand. This is very, very unique case because we developed the technique that at the same time that we did the distraction in the beginning, remember, please? Mm-hmm. So, and then during the MMA, we prepared her for very, very complex surgery. We did this distraction after MMA.
And that's not a TAD expander, is it?
No, it's just a SARPE. It is
a SARPE.
Yep. So, and this is so again, with your medical eyes, the way that you look at this, look at this. Look at the condyles. They are corticated. All right. Yeah.
The left,
this is healthy condyle.
Is trash.
And this is after. Yep. And this patient had very, very poor condyles, the airway, and how enlarged the airway and face. This is the beginning before the middle one is after. This is after. And she's a referee. in basketball referee, and this is before and this is after.
Wow. Looks
And
like
she has
different people.
I need to send you this again, is a testimonial that I'm not going to screw it up. I send it to you.
Okay. Fantastic.
So now we did significant number of these cases, but then we had the long-term watch of the significant number of these cases. Remember Dr. Zaghi and Gimino, they showed that the success rate for these surgeries are 85, but cure is 38. When we look at 21 consecutive cases that we did, and they were consecutive because the same sleep center, the same surgeon. So, and from 21 that we did expansion in the stage 1 and stage 2 MMA. So from the 21, 2 of them we failed. So the majority did not improve.
Failed to get a cure. Which
failed
means
to get
AHI sub 5.
That's right. So it means that AHI from the beginning, from one of them from the, let me see that what was before. So pre-AHI was actually, this was 15, got worse. Why? Yes.
Allergies. Weight gain.
Weight gain. Yes. Good. And then the other one was 42 male. And then he'd improved to, so the
That's
success.
still pretty good. 72 to 42 is pretty damn good.
That combination, which I showed you in the journal of the American Journal of Orthodontic, they show that. Remember expansion and advancement? Success story can push it to 91.7. Right? So it's better than, so micro-implant assisted nasomaxillary expansion. I know that you call it MARPE, we call it MAIN and DANE. This is, and Ron, once you ask me, can you expand the mandible when you don't have crowding? Yes, we can. But requires a special type of approach. So this is a patient 17 AHI, and then desaturation 89. We stabilize her with the Apnodent, Apno-TX. She responded with a split night PSG 3.9. She was managing the sleep apnea okay. And this patient didn't want to do any surgery. She said, I don't want to have any surgery. So we did what we call MAIN. In the book and our articles, this is called MAIN, micro-implant assisted nasomaxillary expansion, which you call it MARPE. So we just expanded the maxilla, and this is bone and Tooth-Borne. And now that we expanded her maxilla, she says, and we say that, now we expanded, since you didn't expand the mandible, we need to wait till your jaw is stable, then bring your teeth together. That's the advantage of, doing the arms, Tooth-Borne, Bone-Borne. So she said, I don't want to constrict my upper jaw. So she went for the DANE. So we expanded upper and lower. And you can see that the lower, and this is Airway. AHI dropped to under 5. And this one also published. So that's the answer to your question.
Can we see the before and after on that case? I want to see the aesthetic outcome.
So here we go. This is before.
Mm-hmm.
Not that much difference, but that was a struggle to keep it the same.
Oh, I think there's a lot of difference. I think she
looks a wider smile, but at the same time, we really struggle to be sure that her lip doesn't drop back.
What do you mean her lip doesn't drop back? You can create lip incompetence doing this?
Yes, I show you. Next case. So I knew that you were going to ask this question.
Well, lip competence is a very not discussed enough thing. It's a very important functional consideration with jaw surgery and with all treatment.
That's right. So, Ron, this is a case that is similar. It's a little bit younger. The other one we started 23, disease, 17-year-old with severe TMJ issues, and doesn't have significant crowding, but she has enough crowding. And we do it without even crowding. And again, expander, I want you to pay attention to the front part of it. And we discussed it, if you remember, in my first presentation. I mentioned that how important to protect the anterior teeth especially in Caucasian patients, they don't drop back. So she had the lower, expansion of upper expansion, DANE, and we call this still main, no surgery, just like MARPE. Expansion system used in the main and DANE are Tooth-Borne, Bone-Borne expanders, providing nasomaxillary skeletal expansion. And you can see it. But they need to be proportional. And this is something that I want to make a point here. I want you to pay attention, Ron, to the back part and front part. We can expand the posterior 10 millimeter wider. There is nothing that to hold us back. But at the same time, I want you to pay attention to a couple of things. The way that they did the mandible, we expanded the lower part more than the upper because her chin could not be too wide. All right?
For aesthetic reasons.
Yeah, for aesthetic reason, this part, the dental-alveolar part, is about 10 millimeter expansion, but here is about 5 millimeter. And then in the maxilla, you see here in the back floor of the nose, it is less in the back and more in front. And the reason comes. So again, she's wearing the appliance. She's recovering. And this is right after we remove the expander. You see still the areas are healing. I want you to pay attention to this. This is published also. I want you to look at the couple of things. First of all, the expanders bonded at occlusal. Why we came up with this conclusion to put it on occlusal, which is a part of the pattern? Because part is aesthetic. Look at this. She doesn't show anything from outside, right? And then the other thing is
no molar bands that you can see from the outside. Sure. Yep.
Especially for adult, because we see a lot of adult patients that they travel and see that aesthetic is very important to them. And of course, we create a space. I'll show you how we hide it. But then the other part of the putting this occlusal on the top of the teeth, the wire, is the vertical control of the maxilla. Not only it doesn't drop down, but that is going to control and create mini counterclockwise rotation is called.
Intrusion of the teeth.
Not only does not extrude and your jaw doesn't drop, actually we are intruding the posterior teeth by doing this. As a result, the lower jaw swings forward, and you can see her chin before and after. Look at the lips, how much protruded was. Now is a little bit more relaxed. And then, of course, airway respond to that. That is not as big as counterclockwise that you do in MMA. But at the same time, it is good enough to improve mild to moderate sleep apnea.
Yeah,
right?
You get auto rotation of the mandible just via clever orthodontics where you're intruding the upper teeth. Now, are all patients candidates for this type of auto rotation?
No.
How do you know if a patient is a good candidate for this specific technique?
Your answer is right in front of you in this picture. All right. So this is the one that when we saw him, I'm going to show this case when I'm done. I don't like to show cases that they're not done, finished. But this is the case that, is important to answer the question that you just asked. So this is the last case, all right, that I showed you here. This is the other case that, so what are the support of the front teeth for the better support of the lips? So you need to support your system, and your expander system need to have arms to support this. That answers one of the questions that you asked before. If you don't have arms, what happens? Right?
You're referring specifically to the arch that's coming out behind the upper front teeth to prevent them from sinking back.
That's right. So
let me ask you a question, doctor. Mm-hmm. If a patient is doing MMA if they're already committed to doing MMA, would you still want to hold the upper teeth forward during MARPE, or do you want to let them come back?
That's the answer in front of you again. Look at this case. He was determined to do the MMA with Dr. Gonson later, right? So we let it go. And if you look at this, he was in the middle of the treatment and his expansion failed. He came from California area to.
I'm sorry, I got confused because I thought that the top left image was this person's expander, but it's not.
This is the last page. This top left is this case.
Understood.
All right.
Understood.
So now,
this new patient that we're looking at, this young man,
the lower right,
has no arch holding his upper front teeth forward.
That's right.
You're going to let them come back.
Well, this is a case of Kevin Coppelson.
This is a mind case.
That's right. This is a mind case. And he did an excellent job. Kevin did an excellent job to do the proper osteotomy, get the expansion. But we wanted the front teeth to come back because with the profile that he has right now before, if we brought him forward for MMA, could not bring him forward enough to take care of these deficient cheekbones and, maxilla. And when we did this, and this is, I want you to pay attention to one more thing. So the thing is that they blame that these arms are not necessary or they create a lot of Tooth-Borne. So this is the one that we use. This is the one that Tomlinson and everybody else use. This is from a partner lab. And he's putting attachments and arms because he knows that if by any chance case goes asymmetric, that's the only way that he can recover from it.
Dentally recover from it.
Yes. Well, yeah. If you want to do a skeletal recover, the only way if you don't have arms is surgery. There is no way. But do you know if this one goes asymmetric, do you know what the easy, and this is education and this is experience that I have. And we were talking about it with Dr. Movahed the other night that we were, presenting. If by any chance clinicians out there that they're just starting this, if by any chance something like this goes out of hand and then becomes asymmetric, the worst thing you can do is removing the expander. The worst thing you can do is freaking out and removing the expander. Because as long as the expander is there, just remove these tats and dentally bring this teeth down and is end of the discussion and done. If you remove the expander, if you remove the expander, this is becoming a surgical, which is almost sometimes LeFort 2 or 3, and I'll show you is coming, surgery to correct it. Go ahead. I'm sorry, Ron.
But if the mid-palatal suture hasn't healed yet, then you could turn the appliance back, couldn't you? Are you only talking about if the suture has fixed into the asymmetric position?
No, you need to pay attention to it. And at this stage, they need to monitor the patient very well. During the expansion, the clinician needs to monitor the patient weekly or bi-weekly. Because if it happens, you can recover from it. But if the case is 3 months out there, unfortunately, even with the Prism expanders, that's not going to happen.
I understand that. But what I'm asking you is the point that you just made about if there's an asymmetry, you leave the expander in so that you can use it to do specific orthodontic movements to correct the asymmetry. Right. But what I'm saying is, does that only apply to cases that are a month or 2 or 3 out and the asymmetry is now fixed in the bone because it's healed?
You cannot do that. You cannot recover from those that they are 2 or 3 months out.
You're saying even dentally you can't recover?
Yeah, you can. You can dentally recover, but if the maxilla, half of the maxilla is out, you can bring the teeth in, but the maxilla stays out.
You can't fix the midface, right?
You can.
So, so the point you made about leaving the expander in, what if you catch the asymmetry after 2 weeks? Do you still leave the expander in, or do you take the or do you turn the expander back and then remove it?
Well, the thing is that in that case, you need to see that why maybe the osteotomy side was not complete. So before you're making it worse, so if you notice it right in the middle of the expansion that one side is asymmetric, so you need to take the X-ray, see that if one side is expanding, prevent it before it goes farther. But then if you have if it's not significant, for example, you want to expand 6-7 millimeter, right? And you'll notice a little bit of asymmetry, and there is a recovery system, meaning that after can I go forward and show you on one case? So let's go. So and then aesthetically, the reason that we put it on the top of the teeth is buccal, one they don't show. So now I want to go through this. If you expand the mandible, then you can double the expansion of the maxilla. This is another concept that is coming. In Maine and DANE and MAPES is coming. Tooth-Borne, Bone-Borne expanders not only prevent and recover asymmetric expansion, but can correct it in referred revision cases. This is the one. What do you see here, Ron?
I see a severe midfacial asymmetry.
Yep. This is the one that our surgeon, we got it, they send us for evaluated, and they want us to do magic. We are not magicians. Do you know what they want me to do in this case? Mandibular expansion to match this level of the distraction that did happen. This case needs probably multiple surgeries, and LeFort 2 or 3 maybe to take care of this.
What did that? Is that a custom MARPE?
This is MARPE this is not dome. This is not mine. This is MARPE.
Is that a frontal maxillary suture disarticulation?
Yeah, this nasal, this is maxillar nasal, this jointment that happened here. And also this area with the zygomatic bone and frontal bone got displaced.
Wait, whoa. I've never seen that before. How the hell did that happen?
Yeah, it happens. These cases, yeah.
Overexpansion? How much expansion is on this? 12, 13 millimeters?
This is about 14, 15, 16 millimeter on one side only.
How did an orthodontist allow this to happen, or did the patient go off and turn this against the orthodontist's will?
Combination. Ron is combination. And again, I repeat it, is a combination. That's why orthodontists usually, when they do this, they cannot run it 100 cases a day. These cases are 1-to-1, right? That's one.
I know.
And then the other one, some of these patients, they take their, the control over their own hand, and they overexpand. I have had patients that we lock the expander, and then he send me the text that, well, I removed the, lock on the thing and I expanded more. So this is the side effect of this.
You put a lock on your expander so that the patient can't.
Our expanders have a lock that they cannot remove it.
That's a feature I've never heard of before on any custom MARPE or FME.
That's a part of the patent.
While we're on the subject, doctor, I'm sorry. Before I forget, what do you think about the FME? Facegenics midfacial expander.
It's coming. It is not. So let me explain. I'm going to answer that.
Okay.
Right?
Sure.
So this is not FME. Of course, you see that, is expander and, is a Bone-Borne and Tooth-Borne expander. But this is another one. This is not the same. This is another one. So this is the one that you see that this right side, this is also the same. This disjointment, here and here. So this patient also had mid-palatal piezotomy, and then this side popped out. And now they want us to do just the DANE to take care of it. Come on.
But it's just going to create a reverse problem on the other side, where now you're going to need more maxillary expansion on the right side to get the right side out of the crossbite after the DANE.
Exactly. Yep. So
plus the midfacial asymmetry is not going to go away.
It's not going to go away. Yep. And
that's a visible asymmetry. You can see that when you look at the patient, right?
Yep.
They look like the one cheekbone is like.
That's right. When you look at the top of the head, this is a little bit forward. And some of these patients also, they are going to have double vision. And
wow, it actually affects vision?
Yeah. Because what happens in severe cases, the cases that they go asymmetric like this is a possibility. And the reason, and I have had revision cases that I have had from somewhere else. And the reason is notoriously, I had a patient that was going to do one of these that you mentioned, not specifically that one, but was Bone-Borne. And then I said, I'm not going to get involved. I just watch this and I'm going to document this till they're done with the Bone-Borne expansion. And then we see the result and get involved. And then, and he already paid. He didn't want to, so went through and did the surgery. Monday morning, this week I talked to him. Monday morning next week, my front desk come back and say that so-and-so is calling and say that, he's in very, very stressful kind of tone and he wants to talk to you. So I stop and come talk to him and say, what's going on? And he said that, Doc, we did this and then I started double vision. I cannot see very well. And the clinician said that we are going to drop this. You are not a good candidate and we just discontinue the treatment. That's it. So that patient, unfortunately, was in a miserable situation because double vision, he was a farmer and he was claiming that when I turn around and on my, tractor or whatever it is, I turn around and get dizzy and fall from the, so it was a kind of bad situation for him. And this was very hard to recover.
Was it too late to just turn the expander back?
We did. They removed the expander. They did just 2 or 3 turns and this happened and they removed the expander and discontinued treatment, but it continued for a while. And we decided that stop the treatment, anything, till patient recover completely. Then he can decide what he wants to do. So, but
doctor, go back to that case.
Sure, here we go. This is not that case. This is not that case.
Oh, this is not that. This is because I was going to say this looks like way more than 2 or 3 turns.
This is This is another case. I'm sorry, I confused. This is
that's a big over.
That case. That case was just they did 2 or 3 millimeter for him, and he had this. But this case is different case. This is not the same.
Yeah, no, this is way more than 2 or 3 turns.
This is a lot. Yep.
This is like 2 or 3 expanders.
Well, this is one expander, and is midline piezotomy, right? And that's the issue. Now, in my experience, expanders with Bone-Borne and Tooth-Borne combination anchorage can provide better nasomaxillary expansion and not only minimize developing skeletal and dental asymmetries, but can recover them more efficiently. And the reason that we do the combination works better for me for what we call Kevin, and the reason is that we know that teeth we used to do a lot of SARPEs and they were successful. Now we add 4-6 TADs, and that's like adding 4 or 6 roots to the roof of the mouth and create anchorage. Why should we give up the previous success that we had with SARPE? And we were treating a lot of these cases, sleep apnea cases, with SARPE. So that's our belief system. But of course, now, this is the answer to your question about no arm expanders, right? This is a patient that...
And when you say no arm expanders, you're referring to my reference to the FME because it's a no arm expander.
Okay.
But this is not an FME. This is not
FME.
It is a no arm expander, but not an FME.
So let me make the distinction. This is no arm expander. I have not worked with FME. And FME is a new appliance and is too early to see any revisions from it. So I cannot make any comment, about FME. So now this, I want you to pay attention to the nasal cavity of this patient. What do you see?
Looks fucked up.
That's a scientific term for it. Look at the occlusal plane on the right side.
Yes, it's the whole palate dropped down on the right.
Yeah. I'm sure the writer, if somebody wants to write a scientific paper about this, it says that severe, then in parentheses F. Because there is no scientific word to describe this. This is our revision. This is what you are getting.
Yeah, it looks like if you're on acid or something and you look at an X-ray, this is what it would look like.
That's right. So the recoveries from these are very, very difficult. And if you had arms, so in main DANE, MAPE, and MAPES, the posterior maxillary expansion, that's the other concept that did I answer your question about this, no arm or just bone-borne expanders?
Yes, but I have a rebuttal.
Okay.
And my rebuttal is, why should arms have anything to do with preventing asymmetry when I would assert, and I'm just posing this to you for sake of argument, I would put forth the argument that doesn't the appliance orientation in the palate have more to do with asymmetry, meaning that it's just about how the jack screw is oriented. If it's placed crooked with respect to the aligned skull, then it's going to expand just in line with its central jack screw. So if the jack screw is crooked, you're going to expand crooked and you're going to get an asymmetry. What do arms have to do with that?
So look at both of these expanders. Is ours for main, and this is Kevin Coupelson's for the way that he does it.
A partner's custom MARPE on the right versus your appliance on the left.
Yeah, custom MARPE from, I believe that this is Partners Lab. They do excellent job. Beautiful. This is a beautiful expander. All right. So here, Kevin is incorporating 10 teeth, 5 on each side. Right? Makes sense?
Yes.
They are in dense bone. Do you agree with me? They are predictable. Ron, the roof of the mouth is not predictable. Right? The roof of the mouth, today, this is the technology that you see on the right side and left side. We call it anatomically driven TAD insertion. What does it mean? It takes me about an hour to decide where these TADs they go. So it means that I send a CBCT of patient, a scan of the patient, the technician match them together and give me a composite, right? Then he comes online, is like surgical planning, and we spend time millimeter by millimeter, right, on the roof of the mouth, locating the bone that we can put the screw in it. Make sense? Kevin did the same thing. He decided this is the best position, and clinician always involved, especially great experienced clinician like Kevin, right? Coupleson. So he did it, right? Now, the roof of the mouth on the consistency of bone is very, very weak. Not every area of the roof of the mouth has bone. So if you have arms attached to roots that they have predictable anchorage in the bone, the likelihood of going asymmetric is much more. You just put it in the roof of the mouth and one side bone is weaker than the other side. And then that side goes asymmetric. That's the reason.
I see. So the argument that you're making is that asymmetry is not caused primarily by initial orientation of the appliance. It's caused by a distortion of the appliance that occurs during expansion as the appliance shifts due to differential resistance on either side of the palatal bone or in the skull. And then so the appliance starts straight so that you wouldn't get an asymmetric expansion, but then it moves and it becomes asymmetric because of weak differential anchorage.
Yes, because if bone on one side is weaker than the other one, or thickness of it is a little bit less, it's like putting a nail, in the piece of paper and scratch through it, right? It's not dense to support it and carry the bone and mid-palatal distraction. It's just ripped through it, right? On one side, and the other side does not. So as a result of that, this is the advancement, and I'm not talking about ours. What Kevin is using is the stage of, art, what we need to use now, because it's anatomically driven positioning of the tabs. Scientifically, we know where the bone is and we put it. So if we just put it in the middle of the palate, that the bone maybe is not there and the arms is not there, or there is no actually tabs, is just supporting by bone, I think that predictability still is there. It can expand, but is going to be a little bit less.
And what I would say, just as a counter argument, this isn't necessarily my position. I'm just playing devil's advocate so we can continue to push the field forward. The fact that we are anchoring to the teeth means that you expect that the teeth are going to play some role, which is to say that they are going to absorb some force during the expansion. How can they stabilize if they're not taking some force and then pushing back to create anchorage? That's your whole argument, is that the teeth are serving as anchors. But if the teeth are serving as anchors, then there's going to be some dental or dental alveolar component to the expansion, which I would say, and you can respond, is always a necessary evil at best. If we can avoid dental anchorage, or if we can avoid a dental component to the expansion where the teeth actually move, not just the bone, then that's better, isn't it?
Well, you just open up another can of worms. Okay, let's discuss that. So, all right, as long as the clinician is very, very careful, all right, they're monitoring this case. So, Ron, look at this area. For Kevin's case, you cannot see the buccal, but you can see it in our area. But you see here, this is a bone expansion. Why? Because the roots are not digging into the alveolar bone, right? So
right,
maybe
the teeth don't seem tipped in this, in the left.
So it's not.
They seem a little tipped on the right.
Yeah, but let's look at the case. Let's go back to that case here. Here, you can see it from front. This is the same case. So I don't think that they're tipped that much. You see that the inclination is still, gingiva is out, the incisal edge or occlusal edge is in. So, but at the same time, you have a little bit, because you have a little bit of scalloping here, but it's not significant. All right.
But it's something. It's something.
Something. But look, so I mentioned to you, I believe earlier, there is a classification that I introduced for, airway, which is the classification start with the nasal cavity, behind the palate, behind the tongue, below the tongue, and is already published in another book, and in the new book also. So that classification has a role here, because if just imagine, Ron, the mouth is like a box, right? So the teeth, they're like a box around their tongue. Do you agree with that?
Mm-hmm.
All right. So if the arches are narrow and the box is narrow, what happened to the tongue? That is the set volume, is the sac of fluid that cannot be squeezed. It's just a sac of water or fluid inside this box. If you squeeze the walls of the box, that tongue is going to squeeze back to the airway. Do you agree with that?
Yes, fluids can't be compressed. That's the whole premise of hydraulics.
So even the dental expansion, that's why some of the dental expanders, they work, and I'm not defending them, but at the same time, dental alveolar expansion has a merit. The same that the SARPE has a merit. So these new toys should not distract us. These are toys. These tabs are new toys. But we have played with this dental alveolar expansion that improves the tongue. So that is, even if we get a little bit, because it's unwanted, we get a little bit of dental alveolar and get significant. But even the dental arches, as long as they are not significant enough that destroy the bone here, 1 or 2 millimeter is acceptable, but not beyond that.
So you're making the argument that actually it's not just about skeletal expansion as it pertains to improving nasal breathing. We also, in many cases, want oral volume increase, which we get partially through dental expansion.
Exactly. Exactly. So, Ron, the thing is that when we send this patient we give them the oral appliance and we send them for a sleep test, the technician that night, what it does, if somebody has experience with the sleep apnea and oral appliances, what they do, they give the appliance to the patient and then monitor or titrate it. What they do it, they advance the appliance sometimes one turn at the time. The lower jaw comes forward and see that how airway performs in a sleep. This takes very, very little volume change. So suddenly the airway is not obstructed anymore. So any millimeter of expansion, including dental expansion, can count. So we should not negate them.
But if you could achieve the same intermolar width increase through a pure skeletal expansion, wouldn't that be better?
Like, what do you use for that purpose? What do you have in mind?
I have in mind whether it's the FME or whether it's a theoretical future armless expander that has some way of using only the palatal bone to achieve expansion, where let's say we're going for an 8 millimeter intermolar width increase, right? Let's use a round number. Let's use a 1 centimeter intermolar width increase. If we can get a 1 centimeter pure skeletal expansion instead of 6 millimeters skeletal, 4 millimeters dental, or maybe 7, 3, 8, 2, that would be better, because that's also a nasal breathing improvement and a cheekbone enhancement, and without any periodontal compromise of the pressure on the teeth being pushed out. And can FME do that? I don't know. Probably not, right? Maybe in some cases, yes, depending on the nature of the bone along the midline. But I still think that theoretically, if the technology arrives someday to be able to get that anchorage, that is a kind of gold standard. And I appreciate that Facegenics is striving toward that end. I think it's the right idea. Whether or not they've achieved it, yet to be determined. We'll check back in on that in a year or two. Okay. When we've seen a couple of 100 cases play out.
Exactly. So we are not going to talking about that appliance because we don't have a case history of that. But at the same time,
fair enough.
You are the clinician, and we call it appliance X, right? So it is a bone-borne appliance. Doesn't have any arms. Mm-hmm. So you are the clinician, Ron. You put that appliance X on the roof of the mouth, and you expand it 10 millimeter, you said?
Sure.
And the appliance doesn't have any arms, nothing to the teeth. Right. So when you expand 10 millimeters, how long are you going to wait till you remove the appliance?
6 months minimum.
Okay. So Ron, look at this case that Coupleson did here. All right. Mm-hmm. So this is a case that he just expanded, and we wanted to front teeth they come back. All right. So he could get a better maxillary advancement during surgery. Right.
So
it means that the lips are putting pressure here to bring it back, right? So in this case that I put the arms behind it, can these teeth come back? They can't.
No.
Right. So the same thing here. In case of Coupleson's case, these teeth are coming back because we wanted to come back, right?
Mm-hmm.
I have a question for you. And this is matter of 2 weeks. When you see this picture after expansion, all right? Just imagine that you expand the upper arch 10 millimeter, run the teeth into these cheekbones, and leave them 6 months. What will happen to them?
They're going to tip in crazy.
Like what? You expand them 10 millimeter. How much do you think that they can come back? 2 millimeter, 3 millimeter?
I would say maybe 3 to 4 each side.
Well, so you lost the dental expansion on that. Remember that dental expansion is important as a skeletal. So, yeah. So the thing is that these are the things that after dying, makes sense. What did you say?
Yes. That I understand that there's, yes.
So you expanded the base of the bone, and there is a recovery from it. it's not end of the world. So you use this and you expand. And you know what? My mentor that I learned expansion, MARPE, do you know who was? I'm not hearing. I'm kind of surprised, at your program, Ram. You're bringing everybody talk about MARPE. You never brought the originator of this, science. Do you know who was the originator of this science?
Juan Moon?
Yeah. Why you don't invite Juan Moon? I learned it from Juan. I have a picture when I took the course. So Juan
That's a
Moon,
great question. Yeah. I don't know why I haven't had Juan Moon on.
Juan invented this and tried with a lot of these. And he presented a lot of side effects that you put it with arm. And then if you look at his cases, that it started beginning with no, what we call arms, and then later scientific areas, like University of West Virginia, Dr. Nunn, cases that he shows, they're all armed with Juan Moon's expander.
Well, right? The MSC had no arms. People were adding arms, but why did Juan Moon make his appliance with no arms then? If he
in the beginning was that Bone-Borne, but later he realized that the side effect, and these guys are very, very. You need to bring Juan Moon and Peter Nunn, these are scientists, these are academicians, these are the chairman of the Forsyth University, chairman of the West Virginia. So, and I'm sure that they're willing to talk to you.
I met Juan Moon at the Forsyth Clinic in Cambridge, Mass, which is only 40 minutes from where I live. I met him in 2021. I know him. I brought him a gift from Russia. I brought him a small bottle of vodka and some fine chocolate because I know he's a kind of a foodie based on just his Facebook profile. Seeing all of the amazing dinners he has as he travels the globe. Yeah. But I should have Juan Moon on. That's a great point.
You need to bring Juan Moon, and you bring the Peter Nunn also. I'm telling you. So again, in Maine, DANE, MAPE, and MAPES, the posterior maxillary expansion is proportional to the mandibular expansion with DANE to avoid telescopic crossbite called brody-bite. You know what is brody-bite.
It's the worst thing in the world.
So the reason that they say that why in his expansion system, his expansion in the front is more than the back, look at the way that we are expanding the mandible. That's why we don't get distraction, because these are condyles. Vertically, we just rotate them, right? Okay? We don't distract them. So as a result of that, look at these two arrows here. Look at the arrow in front. These are 10 millimeter in front, just 2 or 3 millimeter in the back. If you expand in the back, 10 millimeter, that's why this case that I showed you, that you said that F word, that was 10 millimeter, 15 millimeter in the back. That's a problem. That's why the clinicians, that they are very conservative on expanding the maxilla, not more than 4 or 5 millimeter, because the mandible is going to be brody-bite now. That's the problem. Right. So I wanted to make that.
We need to go back to that last slide, because you just clarified a very, very important misconception that I've had for years, and that a lot of my audience has had. Your point about why DAME is safe for the TMJs. DAME is it is rotating the condyle in the joint, but it's not bending it like this.
Nope, it does. So
it's okay to do this, but it's not okay to do this.
No. So look at I put it this way. So this is a mandible, right? Makes sense?
Yes.
This looks like mandible.
Yes.
Right here. So we do this.
Yes. So the thumb is rotating.
Yeah. The right thumb is rotating.
But the thumb is not flaring out.
No. It doesn't do this, and it doesn't do this. Yes.
That's the key.
That's the key. But at the same time, you need to be very careful. After a lot of trial and errors, we noticed that if you expand the posterior too much, and also, Ron, I have a question for you. You're as good as the other clinicians. Your knowledge, more than some of them. I mean, compliment to you.
I appreciate
They're educated, but at the same time, I have a question for you. So just imagine that we do a cut here, right here, okay? Right here with MRI, all right? And we look at the top of the face, right? What do you see? Nose?
Mm-hmm.
And then it goes back, face in the back. The airway is the same. The front is narrow. The back is not very narrow. Most of the constriction is the anterior nasal valve, just what we call preform area of the nasal cavity, a little bit back of the nose, which is in this area. There it usually is wider here, this area. The anterior is the most constricted, right? As a result of that, expansion, and I am going to make a point. Dr. Gimino and Lou from Stanford University, they did a lot of research with expanders. The time that MARPE was not a case, right? MARPE was not even existed 15 years ago. And then the research showed that when they expanded the palate and nasal cavity of kids, all right, with no MARPE, they had improvement of sleep apnea. Do you think that with those, primitive expanders compared to MARPE, what Kevin Tomlinson can do, do you think that they expanded the posterior maxilla? There is no way. They were expanding the anterior more, and then the One Moon also supported that with his expander, front is more than the back. There is not necessary to expand the back of the maxilla 10 millimeter. First of all, you get Brody bite if it's extreme. And also most of the, narrowness because of the way that it is the nasal, and going back gets wider. That's my argument. And a lot of people, they argue with me on that. They disagree.
Well, Casey Lee would disagree with you on that.
Well, actually, I appreciate Casey, because we, on and off, remotely, we work together. And he made a comment that I love it. Can we go to the next subject? Casey Lee brought up one of the dilemmas that we have. Now, stay with that. This is the one that I wanted to show you, the recovery from the asymmetric. I showed you this before. They started a case, all right, from Florida. And then because of anatomical and maybe the cut, one side went off. So this was the expansion, maxilla and mandible. But look at this, the left side here. Do you see my mouse? Is getting a little bit out, right? We knew that we can recover from it. The mandible is symmetric, the maxilla. Look at this central, how much asymmetric was. So we left it alone. We finished it, let it heal for 3 months, all right? Because the amount of the dental recovery and the bone here, the maxilla was not out. It was just dentoalveolar. So what we did, because we did the SARPE cuts, we knew that it's dentoalveolar. So then we removed this pad here, all right? And then gradually reverse this. We brought it symmetric dentoalveolary and then remove the appliance. And then that's the way that, the case it became symmetric. All right. That's the concept of asymmetric. Now, back to my friend, Casey. And I love that presentation and I watched it several times because he has a great point. First of all, Casey is one of the great clinicians that was doing MMA. All right. And then he did the DANE and he has a valid point on DANE. Ron, do you remember so let me read this. Severity of the, okay. One more concept before I brag about Casey. All right. Severity of surgical procedures. Surgically facilitated orthodontic therapy, SFOT, versus DANE. All right. They call DANE is unethical and aggressive. All right. This is SFOT and this is DANE. Which one is scarier?
The SFOT is so graphic that it's going to get this video probably shadow banned because of just this image. No, I agreed. SFOT is brutal. SFOT is brutal.
There is no way. The DANE, look at this result of DANE. Ron, look at the result of the DANE. So this is the actually expansion that we get. The nasal cavity inside is intact. So the cut, the dome also doesn't go. I don't believe that dome goes inside the nasal cavity. In walls are intact. So we get the true nasal expansion. And you can see it inside the nose, how much expansion. You see that cheekbone is very, very minimal, very minimal. And then you get a lot of the area of the dentoalveolar of the upper and base of the nasal cavity. And mandible, gonial angle to gonial angle, no distraction, is just the rotation. And then here also you see that the nasal bones, they don't get any change there.
Because of the dome assist.
Yes. Yep. And yeah, we call it DANE, but they call. I agree with that, and it's almost the same. So now so based on
is that middle green line changing much?
Yes, it is changing a little bit. See here a little bit because the inside is intact. Most of it is the yellow arrow base, and then a little bit here, but nothing on the top here. And we don't want anything here because in adults it can get pop out. It's not a joke.
A major cause of severe asymmetries.
That's right. And you can see now this is outside. I mean, you can see the bone. And then, and this is what you get. And the question, why is the skeletal expansion of the lower jaw so important? Because you can enhance the maxillary expansion. Micro-implant assisted, this is MAPE. All right. But before go to, I want to talk about comment that Dr. Casey Lee made. So during his comment, he said that we did a lot of the MSDO, and then the problem that it does is making the lower mandible, the mandible longer, and then you end up doing a lot of MMAs to cover from it. Remember that?
Yeah.
And we experienced that. The cases that I showed you so far, that is DANE and upper one, we call it DANE, they were a little bit class 2-ish. The mandible is going to get 2 or 3 millimeter longer with DANE because of the configuration of expansion. It gets a little bit longer. It's a little bit of a Pac-Man-y type expansion, so you get a little bit of projection. Yeah. So see this, if this is my mandible, so we turn it like this from here to here, it gets a little bit longer. When we rotate this from here, the arrow here, to the, this condylion here, we call it, gets a little bit longer because of rotation around the vertical axis of the condyle.
So when you do mandibular expansion, you get more advancement of the mandible than you get advancement of the maxilla with maxillary expansion. Is that true?
Right. That's right. So we felt this. We noticed that on class 1 cases that then patient counts overjet a little bit class 3. So that's why we had to go to the next level. And that was the evolution in the technology. So MAPE, micro-implant assisted protraction expansion. For the children that they are very plastic, right? So this is a case, remember I mentioned to you, this is coming from another clinician that they expanded and the front teeth, they drop back. All right. Now look at this edge to edge. This is where we are starting the case. All right. Posterior, open bite because the anterior teeth are hitting. So this is that technology, and it's published in the book.
This is the first time you're showing me this expander.
Because it's in the book.
it was blocked out last time we did the interview.
And the reason was that the patent, because of a continuation, of the patent, we needed for that period of time. Now here we go. Look at it. All right. So this appliance is very, very unique. This is the future of orthodontics. So the appliance can bring the teeth forward, can bring back, forward, impaction. So this appliance is a multi-process appliance, right? And of course, it's patented with several patents. last time that we were talking about it, the second patent was going through continuation in part. We couldn't, show it, but now you can see it. All right. So is it all the teeth, they come together at the same time. All right. And it's just 4 millimeter. That's it.
So can we go back to that, please? So you're suggesting this appliance can help fix the class 3 that's created by the mandibular expansion.
Exactly. But as long as it's within 4 millimeter discrepancy.
And that's because 4 millimeters is the limit of what you would want to do with dental anteriorization?
That's right. Dental alveolar protrusion. The science shows, and I have a question for you. When they do the SFOT, how much expansion do they get with SFOT?
I think there's a lot of debate about that, but I would say it's modest, on the front or on each side.
Yep.
You're asking me?
2 or 3 millimeter on each side.
A few millimeters each side and maybe a few millimeters in the front.
Yeah, that's great. I mean, that is a good case to take care of the mild to moderate maybe crowding, right? But at the same time, when we bring this forward for kids, which we do it up to age 14, not more, 14, 15, right? 16, we are pushing it, maximum 4 millimeter, depending on case. But
you're saying that you wouldn't do this for an adult?
No, not MAPE. For adult, it's called MAPES, is micro-implant assisted protraction, expansion surgery, requires surgery. All right. But for children, we call it MAPE. There is no surgery, just putting, tats. Right. And that's it, because they're plastic enough that we can stretch the bone a little bit. The skeletal expansion is skeletal. They expand, the transverse is skeletal for kids. Doesn't need surgery and is like MARPE. But the advancement is 3 to 4 millimeter of dental advancement. And what else? If we add the face mask to it and they wear the face mask to this, a component here, which is attached to the base of bone. Remember? So now we can get some skeletal advancement also. So if you look at this before and after, and I want you to pay attention to front area. Do you see any stress in the gum in that area?
It doesn't appear to be.
Yeah. This is before and after. And this is before and after. She's holding her head a little bit up, but look at the prenasal area, that how much improved, and look at her airway.
Yeah.
But this is a 4 millimeter. This is a skeletal, meaning that the face mask can bring it another millimeter or 2, even at this age. But I want you to show, I gave you this case, if you remember. You asked me for MARPE, and I gave you this to present. This is a case with how many millimeters you think that is negative overage? That is 4 or 5 millimeter? 4 or 5 millimeter.
Mm-hmm.
And this is MAPE.
Mm-hmm.
What do you think?
Mm-hmm. Nice.
Do you see it is, we are not doing magic here, and it's 3 or 4 millimeter maximum. But look at the profile of this patient before and profile of patient after. Now we have clinicians, that they, for example, this weekend we had orthodontists and, group of interdisciplinary clinicians, they come and start learning about this. So is available. So let's go to, this is the, for adults. I showed you this case before. She had 4x extraction. She didn't have any surgery and AHI was mild. And when we did the Apnea-TX split night sleep test, she responded very well, dropped to 0.8, much better than 5. And then we did this appliance. Now, remember, Ron, I mentioned to you that she was so narrow, we had to do 2-level expansion, all right? 2 expanders. This is the first expander, all right? I want to show you and repeat this because I showed you in the first presentation. the screw went long and went into the into the septum, right? And created this asymmetric. This is the one that you said is like parenthesis F. Make sense?
Yeah.
I try to be scientifically, but this was
it was my words, not yours.
Yeah. So, but look at this. So when we put this appliance in, this appliance can do a little bit of intrusion. Not significant, but you can do a little bit. And then, you can do actually significant to take care of gummy smile. And this is at the end, right? And then again, do you see any stress gum on the top? In MAPES, the whole upper jaw can come just 3 or 4 millimeter and has the safety lock that nobody can break it. It's a very, very sophisticated,
so
system.
that they can't overexpand?
This one they can't. No.
So what's the difference between the MAPE and the MAPES? The MAPE for children, the MAPES for adults?
That's right. As a MAPE surgery, it has a surgery. And a surgery is like a SFOT. The same time that they do this, then they're going to do the corticotomy and backbone, and that's the patented technology.
I understand. So for adults, if you're going to do anteriorization of the upper teeth, you require the SFOT to happen with it.
That's right.
And is the MAPES doing dental expansion or dental-alveolar expansion? Is it actually bending the alveolar ridge, or is it just pushing the teeth?
So the MAPES the transfers is a skeletal. And we do it the way that we do the SARPE cuts, the same as dome.
Right.
The transfers is like dome, but the advancement is like SARPE and is the bending the bone. And of course, we add some volume of bone. So practically, we create a little bit of bone and move. So it is a combination of bending the bone, which is about 1 millimeter or 2. And if we can create a good bone by what we call the corticotomy and bone augmentation, so another millimeter, so we can, that's why we maximum 3-4 millimeter.
And would you say that the MAPES is really best for patients that don't plan on doing an MMA?
So MAPES is for patients.
Is it creating compensation for someone if they want to do an MMA someday, that they would have to, now they can't get as much skeletal advancement?
It is. You're absolutely right. For patient, when we go through these, patients said, absolutely no way in the world I'm going to do MMA. All right? And you had one on your program before. He said that no way in the world and I'm going to do Eton. He said, no way in the world I'm going to do MMA when we started. Right? That's why we have patients that they don't want to do, MMA. This is the way to go. But you know what? If patient is determined to go to MMA, I show you the way that we did with Kevin. Let the front teeth relapse so we can maximize the advancement of the jaw and the, what we call maxilla pre-nasal area.
So
Make sense?
Yes, of course it makes sense. So for people that would look at this and they would say, this dental advancement of the upper teeth that you're doing, it's no different than any Tooth-Borne expander like AGA or something like that that's pushing the front teeth forward. Your response is, we're doing SFOT?
Mm-hmm. Well, that response is the same response that somebody, a clinician, does the SFOT has. Well, is the dental-alveolar expansion. And is safe with SFOT, should be safe with this. There's no difference.
I think another
Do you
problem...
remember another hero that we have? Dr. Mew. He did it for the younger patient, 11, 12, all the time with his, appliance, orthotropic, system. He did it all the time with the, upper one. He was bending the bone and pushing the upper one. Is working as long as is within a couple of millimeters. So the answer, again, you said it. You asked the question and you answered yourself. the same clinician that does the SFOT and expect to have 3 or 4 millimeter dentoalveolar, this is it.
Another key difference, of course, is that you're using skeletal anchorage for the interiorization of the teeth, which means that you're not getting any Newton's third law phenomenon, where with AGA, we were also seeing the back teeth flared back.
That's right. Yes.
So you're getting pure advancement.
So the problem, you know what? Actually, all these are the evolution of science and understanding. You know, you mentioned earlier, again, I don't want to badmouth anybody. So you mentioned when we were talking about the book Braid, you mentioned about the appliance that you said that is dental-borne. But at the same time, they started on the new understanding, you know, and again, AGA also starts a new understanding. And that understanding is that why can we expand the site and we cannot bring forward, except that the appliance, and then some clinician, some patient, they took it upon themselves to do it too much. And also appliance, as you said, was the Tooth-Borne. Back was Tooth-Borne, moving back and front teeth. There was no, and it was spring loaded. So this appliance, as I showed this, okay, by the way, look at this profile of this patient. First of all, her sleep apnea cured is under 0.9. And then look at the look at the prenasal area. It's just bringing the dentoalveolar, right? Mm-hmm. This is a patient. She's a physician. She didn't want to have MMA. Dead against MMA, although she had 4x extractions and moderate sleep apnea. So, and the size of the nose is smaller by bringing dentoalveolar forward. So the appliance for MAPE, it is very controlled advancement. So it means that 1/4 millimeter per week, which is like Invisalign. Invisalign is 1/4 millimeter per week expansion if you use it and change it every week. So through a long time, and is self-limiting, so nobody can play with it, advance it too much. And now, remember, my friend, this case?
Yes, the legend.
Yes. So this is a patient that didn't want to have MMA. This is the original Apnea TX. We expanded his lower jaw. Again, appliance is self-limiting advancement, maximum advancement of 4-5 millimeter, and has a vertical control. Remember, the issue of vertical control creates clockwise rotation?
Mm-hmm. Intrusion of the upper teeth allows for auto rotation of the mandible.
That's right. Well, it's going to be intrusion both upper and lower. When we put the bulk between the upper and lower, both is going to have intrusion of the posterior upper teeth and lower teeth, which we don't know which one gets more, but it's going to be shared. And then the vertical control creates the counterclockwise. Aesthetically, it's not pleasing, but guess what? Look at this. This gap, it is going to be over for 2 or 3 months. We give them a fake tooth there. Mm-hmm. It's not noticeable.
Yeah, then they just look like Tom Cruise for a while.
That's right. Look at this. This is the another young clinician. This is expansion, and so it's tolerable. And look at the bone that is generated. So, and then we remove this. You remember the rest of it. You know the story. Look at
even he has a gold cap.
Yeah. Well, the thing is that
how did he get a gold cap? Is there someone in Seattle that does a lot of gold? What's going on here?
Well, the thing is that there is another thing that I don't want to confuse, and that's the term teledontics. Is the medical utilization of dentistry to improve the sleep apnea. So, Ron, when patient does not, and this patient, unfortunately, he had a lot of cavities because of saliva. There was no saliva, and he had a lot of gum line cavities.
No saliva because of mouth breathing?
No, because of the systemic problem that we couldn't have MMA for him.
Okay.
That was part of it. So as a result of this, he had to have a lot of crowns. After we were done with him, we had to do a lot of crowns for him. And guess what? We took advantage of that. And then when the dentist, Dr. Wadwani, was doing the crowns, I created a space between his teeth, which helped. Look at these spaces, right? These are dental spaces that support the expansion that we did. And then he restored it with the teledontics, medical use of dentistry, to support this expansion that we did.
So basically you used restorative dentistry to alter the bite and to make the teeth also look better because you made them bigger to match the now bigger bone so that you didn't have small teeth and big bone.
That's right. And also the making teeth a little bit wider supported the expansion that we did.
So when you put in bigger teeth, it actually stabilizes the expansion?
Well, we cannot do it on everybody. We are not going to put 20 crowns on 20-year-old or 24-year-old, even 40 years old to do this on every single case.
Yeah.
Is the opportunity that we had for this case, because he had to have these crowns because cavities, right? So as a result of that, we took advantage of it. But some patients that they have significant wear on on the teeth because of grinding, those are the ones that they need to have crowns anyway. So we can take advantage of that and expand and make the teeth and the restorations and crowns supporting the expansion. So do you see the area of the expansion healing is completely melt in and not noticeable?
When patients do MAPES, do they ever complain about sensitivity of their upper front teeth or have any issues biting with those teeth?
You need to be watching them very carefully, and you need to be in contact with them. When we start this, as Casey also mentioned, they have my cell phone. They text me at any time that they have any issues. You cannot have a large practice that patient, they disappear and you cannot. So we need, and again, even in this MAPES, even if by any chance they disappear, they cannot advance it more than 3 or 4 millimeter, which is not harmful. But if they start saying that my front teeth are sensitive and they're reacting, we back it up. They're not a good candidate for it.
So some patients are more predisposed to have dental problems with that type of tooth-borne advancement, even with SFOT.
That's right. Yeah. When you, for example, you do it and then you bend the bone, they have vulnerability to do it. So you need to be careful. So no surgical procedures, no dental procedures, no medical procedure is safe. You entering the dental office, you're exposing to yourself to risk. All right. So as a result, but some risks are calculated and they have nice byproducts. Sleep apnea is a severe disease. It can kill. Heart attack, stroke. So these are minimally invasive procedure. When I was talking, I don't want to mention name, but somebody was talking about doing the expansion and he mentioned that 2 teeth died. And he said, big deal. 2 teeth died, but we saved his heart and brain from heart attack. I cannot go that far and I never go that far. At the end of the treatment, each treatment, we should have beautiful smile, beautiful teeth, and longevity. Like first 2 slides I showed you, we are pushing it to 100 run, right? So this patient, we are expecting that we are turning the clock backward, all right? Patient is going to look healthier, several years healthier, and also younger. So that's the capability that orthodontics has these days.
And when you do in the advancement of those upper front teeth, is it bodily movement of the teeth or is it tipping of the teeth?
So and so. It's
a mix
combination. It is because the appliance is attached to the front teeth here. So since is glued to them, we get some, bodily movement, and then the rest of it is going to be a little bit of flaring.
Yeah. So it's a mixed bag, but as you were just arguing, like all things medical, it's a compromise. Like any medication, there's side effects, but the hope is that the cure is better than the disease.
Well, the thing is that, okay, let's look at this. You need to be with so Ron, can you expand the upper jaw 15 millimeter? You can't, not safely. Can I expand the lower jaw 15 millimeter? No, because I'm running the chronoid process to this zygomatic bone and going to lock. So medical has limitations, all right? As much as is unethical, a patient that has hole in the heart, blue baby, we don't treat them because we said that heart is sacred and we cannot do the heart surgery, all right? We need to do it, but we need to be careful because heart surgery is not free of risk, but it's saving the life of a baby, right? Or adult that needs to have cardiac surgery. These procedures are not free of risk, but at the same time, risk benefit with very, very close supervision, they're going to be safe.
Yeah. I'm happy that we went this far, and I think the podcast got better and better the longer it went. And so I'm glad that we did what we did.
Great. Thank you very much. And hopefully that will be helpful to, again, whoever that watch this, people that they don't have that much experience. Hopefully we didn't talk so high that it was not comprehensible.
I think you really met people where they're at, Doctor. So thank you so much.
Sure. Thank you very much, Ron.
And your book, Doctor, how can people access your book?
In the middle of the March, it is going to be available.
March 2025.
That's right. For the pre-purchase, I believe.
On Amazon or where?
I believe that is on Amazon. And Ryan is going to let you know. And then you can announce it.
Okay. Link in the description below.
Yeah.
Okay. Thank you,
Thank you very much. Sure. Bye-bye.